Have you ever stopped to think about how just a seemingly small change in how we give medicine could actually completely change things for millions of people?
It's a really important point. It's not always about the breakthrough discovery, is it?
Exactly.
Uh,
Sometimes it's just finding a smarter way, a more, human way to use the treatments we already have. Okay, let's unpack this.
Let's do it.
So today, we're doing a deep dive into this really fascinating study. It could fundamentally shift how a major cancer drug, pembrolizumab, many of you will know it as Keytruda, is given.
Hmm.
Imagine going from, sitting there for a long 5E infusion to just getting a quick shot under the skin.
A huge difference.
That's the potential game changer we're looking at today.
It really is.
Our mission, then, is to break down this phase 3 trial. It's called 3475AD77. It directly compared this under the skin, or subcutaneous S.C, pembrolizumab, with the usual intravenous IV way.
Both combined with chemo.
Right, both with chemotherapy for patients with metastatic non-small cell lung cancer. This could be massive.
And what's truly fascinating here, picking up on your point, is just how big an impact this seemingly simple shift could have.
Mm-hmm.
For years, IV has been the standard.
Right.
But the reality for patients, hours in a chair, often multiple times a month, that's a huge burden.
A huge time commitment, yeah.
And for the clinics, the hospitals, it's a constant juggle. Resources, space, staff time.
Managing infusion chairs must be complex.
Absolutely. So this isn't just about, making it slightly more convenient. It's potentially transforming the whole patient journey and the whole system of delivering care.
That really hits home. Because when we talk advantages for subcutaneous delivery, it's more than just avoiding the needle prick of an IV, isn't it? What about the sort of emotional side? Reducing that time burden?
Well, it's profound. Studies consistently show much higher patient satisfaction, a significantly lower emotional weight, less anxiety, less stress tied to those long clinic visits.
I can imagine.
And patients they prefer it overwhelmingly. Then you flip to the clinic side, shorter visits, obviously, less demand on nurses and pharmacists, better efficiency overall. It really changes how you manage patient flow, appointment scheduling, everything.
So, okay, if it's got all these plus points, the big question is, can we actually get these benefits without losing any effectiveness? Especially with a drug like pembrolizumab.
That's the crucial question, and that's what this trial aimed to answer. Pembrolizumab Keytruda is already approved worldwide, lots of different cancers, including this type of lung cancer.
Right. Standard of care for many.
Exactly. So the goal was, can this subcutaneous version deliver all those practical wins while being just as good medically?
And how did they make the subcutaneous version work? Just inject the same stuff?
No, it's quite clever, actually. The specific formulation, MK3475A, includes an extra ingredient called hyaluronidase alpha.
Hyaluronidase alpha.
Okay, think of it like this. It temporarily makes the tissue under the skin a bit more permeable, like loosening the weave of fabric for a moment. So the drug, which is a relatively large volume for a shot, can disperse and get absorbed more easily and evenly. It's a neat bit of bioengineering.
That is clever. So it's not just simpler, it's biochemically assisted simplicity. Okay, let's peek inside the trial then. A global phase 3 study, open label. 3475AD77.
That's the one. NCT 0572D75 Talon, if you want to look it up.
And they randomized patients 2 to 1. So twice as many got the subcutaneous shot compared to the IV.
Correct. And both groups also got standard platinum-based chemotherapy alongside the pembrolizumab.
Now, who were the patients?
It was 377 patients, all newly diagnosed with stage 4 non-small cell lung cancer. And importantly, these were patients without certain specific genetic mutations in their tumors, EGFR, ALK, or ROS1.
Okay, why exclude those specific mutations? Why was that important?
That's a really key point for understanding the results. Patients who do have those mutations, EGFR, ALK, ROS1, often have very effective targeted therapies available, pills usually, designed specifically for those genetic drivers.
So they wouldn't typically get pembro plus chemo first line anyway.
Precisely. By excluding them, the researchers focused the study on the exact population who would be candidates for pembrolizumab plus chemo. It makes the comparison between the shot and the IV much cleaner, much more relevant for this group.
Makes sense. And were the groups well matched otherwise?
Incredibly well balanced. Age, gender, cancer characteristics. Everything was very similar between the SC and IV groups at the start. That gives us real confidence in the results. Any differences we see are likely down to the delivery method, not underlying patient differences.
Okay, solid design. So with that set up, what were the primary goals? What did they absolutely have to prove?
The main goal was all about pharmacokinetics, or PK basically, how the drug moves around in the body. They needed to prove non-inferiority.
Non-inferiority, that sounds a bit negative, like not worse.
Kind of, but it's a standard regulatory term. It doesn't mean they were aiming for just as good and no better. It means they had to statistically prove very rigorously that the subcutaneous method was at least as good as the established IV method in terms of drug levels.
Okay. And how did they measure that?
They looked at two main things. First, the total drug exposure over the first 6-week cycle, that's the area under the curve, or AUC, basically the total amount of drug the body sees over time.
Right.
And second, the trough concentration at steady state. That's the lowest level the drug reaches in the blood just before the next dose is due, once things have stabilized after a few cycles. It's a key measure of sustained drug levels.
Did they prove it? What were the results?
They absolutely did. The results were really clear. For that first cycle total exposure, the AUC, the geometric mean ratio, the GMR, comparing SC to IV, was 1.14.
So slightly higher exposure with the subcutaneous.
A little higher on average, yes. And the statistical significance was overwhelming p-value less than 0.00001. Easily met the non-inferiority requirement.
Wow. Okay. And the trough concentration?
Same story, even stronger signal in a way. The GMR for trough levels was 1.67. Again, p less than 0.0001, confirmed non-inferiority there too.
So the drug levels were definitely not worse with the shot, and in fact seemed maybe a bit higher overall, especially the trough levels.
That's right. The overall exposure and the minimum levels were shown to be non-inferior. And yes, the steady-state trough levels were notably higher with the subcutaneous form. But, and this is important, these levels remained well within the range known to be safe from previous studies with IV pembrolizumab.
Ah, okay. So higher, but not dangerously so.
Exactly. And interestingly, the peak concentrations, the highest point the drug reaches after administration, were actually lower with the subcutaneous shot compared to the IV infusion.
Which could be a good thing. Less of a sudden spike.
Potentially, yes. Sometimes lower peaks can correlate with a slightly better side effect profile for some drugs, though the overall safety was similar here, as we'll get to. But the key PK takeaway, non-inferiority convincingly demonstrated.
Okay, drug levels are solid. But the ultimate question, did it work against the cancer just as well? What about efficacy?
That's the other crucial piece, and here again the results were remarkably similar. Very reassuring.
Tell us the numbers.
Okay, objective response rate, ORR, that's the percentage of patients whose tumors shrank significantly. It was 45.4% for the subcutaneous group versus 42.1% for the IV group.
Very close. Almost identical.
Very close indeed. And then progression-free survival, or PFS, how long patients lived before their cancer started growing again. The median was 8.1 months for subcutaneous versus 7.8 months for IV.
Again, extremely similar. So when you see numbers that close in a trial like this, does it basically mean they're equivalent for practical purposes?
Pretty much, yes. In a well-designed non-inferiority trial, when efficacy endpoints like ORR and PFS come out this closely aligned, it gives strong confidence that there's no clinically meaningful difference. The slight variations are likely just statistical noise, not a real difference in how well the drug works.
And overall survival, how long patients live.
That data is still maturing, which is normal for these trials, but the early look shows the survival curves are tracking very closely together as well. Comparable results so far.
Okay, so PK non-inferior, efficacy looks equivalent. What about safety and side effects?
Again, a very consistent picture, and that's really good news. The rates of treatment-related side effects, serious side effects, and patients having to stop treatment because of side effects, all very similar between the two arms.
No big red flags for the subcutaneous version.
None reported. What was particularly interesting and quite positive was the rate of anti-drug antibodies, or ADAs.
Right, where the body reacts against the drug itself.
Exactly. Sometimes that can reduce effectiveness. Here, the rate was very low overall, 1.4% in the subcutaneous arm, and even lower, 0.9% in the IV arm.
Tiny numbers.
Very low. And crucially, the study found these ADAs didn't seem to have any real clinical impact. This is actually quite favorable compared to some other studies of subcutaneous immunotherapies.
Oh, really?
Yes, drugs like esilizumab or nivolumab in their subcutaneous trials sometimes showed higher rates of immunogenicity, these ADAs. So pembrolizumab looks potentially quite good on this front. It's a significant plus. What about reactions at the injection site itself, a common concern with shots? Minimal issue here. Only 2.4% of patients in the SE arm reported an injection site reaction.
And were they bad?
No, all were reported as mild grade 1 non-serious, and importantly, none of them caused anyone to stop the treatment. So, very manageable.
Okay, that brings us to what, for me anyway, feels like the most dramatic finding. Here's where it gets really interesting. The administration time.
Ah, yes. This is the practical game changer.
The median time to actually give the subcutaneous injection was just 2 minutes.
2 minutes.
Compare that to the IV infusion.
Typically around 30 minutes, sometimes longer depending on protocols and vein access.
2 minutes versus 30 minutes or more, that's staggering.
It really is. Think about that from the patient's perspective. Less time hooked up to an IV pole, less time in the clinic chair, less disruption to their day, their life.
It's not just saving 28 minutes, is it? It's reclaiming a chunk of your life back every few weeks while you're dealing with cancer. The psychological impact must be huge.
Immense. And from the clinic's perspective, the efficiency gains are obvious. Faster patient turnover, less demand on infusion resources.
Huge implications for scheduling and capacity.
Absolutely. And just to round out the patient experience picture, they also measured health-related quality of life, consistent between the two arms. No difference. So all that added convenience didn't come at the cost of making people feel worse overall.
Wow. Okay, so what does this all mean? Let's step back and look at the big picture.
Right. So what does this all mean? The study's conclusion is pretty clear and quite powerful.
Which is?
Subcutaneous pembrolizumab looks like a viable, safe, and effective option essentially everywhere that intravenous pembrolizumab is currently used.
Not just this specific lung cancer setting.
No, the implications are much broader. If we connect this to the bigger picture, think about all the different cancers and treatment stages where Pembra is used. Early stage adjuvant therapy, other metastatic cancers.
So this could apply across the board.
That's the implication from this foundational study, yes. The PK and safety profile should translate. For patients, it means, as we've said, massive convenience, less time burden, likely less anxiety.
And for the healthcare system.
Streamlined workflows, freeing up those infusion chairs, chair time is a major metric, potentially lower resource use overall. It could really change how cancer centers operate.
More flexibility, too, perhaps. Especially for people maybe on simpler regimens or in earlier stages.
Exactly. Maybe easier to combine with complex chemo schedules, maybe easier for patients traveling long distances. It just simplifies one major logistical piece of cancer care.
It really feels like this deep dive gives us a shortcut to understanding something that could genuinely, tangibly improve treatment delivery for so many people worldwide.
I think that's fair to say. The 3475 AD77 trial gives really solid evidence. SC Pembro is as good as IV Pembro from a medical standpoint, but with these huge practical upsides.
A powerful combination.
Definitely. And this raises an important question, thinking longer term. If subcutaneous immunotherapy becomes the norm, not just for Pembro, but maybe for other drugs too, how does that change the actual physical layout of cancer centers?
Good question. Less need for rows and rows of infusion bays.
Perhaps. Could treatment shift even more? Maybe more easily delivered in smaller community clinics or, down the line, potentially even aspects of home-based care for certain patients? It really prompts a rethink of the infrastructure.
A fascinating thought to end on how a simple change under the skin could reshape the buildings where care happens. We hope this encourages you, our listeners, to keep exploring these kinds of innovations in medicine and health.